Greetings to everyone. Today's webinar is on improving the quality of critical care for COVID-19 now and into the future. I'm Bob Fryatt and I'll be moderating the discussion with our three expert panelists. This webinar is hosted by the Local Health System Sustainability Project, which works to build sustainable, resilient health systems around the world. As we know, the majority of those who become infected with COVID-19 have mild or no symptoms, but a significant number go on to get a severe illness, with some requiring admission and critical care support with significant levels of mortality. In this first slide, we show some data taken from two large studies in New York and England in 2020. The study in New York on the left covered death rate for hospitalizations in 3 big centers, and the study from England looked at outcomes in intensive care in high dependency units across 108 centers. Both studies showed drops in mortality over time, adjusting for factors such as age, sex, ethnicity, and comorbidities. These changes have been reported elsewhere, and various factors have been proposed to explain them. These early studies were conducted quickly to provide rapid evidence and likely overestimated mortality. Countries affected early in the pandemic may have had their health facilities overwhelmed, having a knock-on impact on quality of care and mortality. Another explanation is that non-pharmaceutical interventions such as masks and social distancing may have reduced the level of exposure to the virus, reducing severity of illnesses. But there's also been an incremental improvement in the quality of care of COVID-19 as a result of learning on the most effective forms of care and treatment. So today we have three experts to discuss this in more detail. Next slide, please. First, we have Cholpon Asambaeva, who is the country director of the Local Health System Sustainability Project based in Kyrgyz Republic, Central Asia. She will share her experience of national support and coordination. Then we will hear from Dr. Basheer Khassawneh, Professor of Pulmonary Sleep and Critical Care in North Jordan, who will share frontline experience during the COVID-19 surge there. And finally, we will hear from Dr. Lipnick, an anesthesiologist and intensivist from San Francisco, who provide a global overview of what's been happening in this area. I'd like to encourage all our audience members to submit questions during the chat, using the chat box on your screen. So we will start with the experience in Kyrgyz Republic. Cholpon, over to you.
Thank you very much, Bob, for welcoming. It's a great pleasure for me to present the country experience to COVID response, critical care and case management. Next slide, please. Kyrgyzstan is a small and mountainous country with a population of 6.5 million. The first 3 cases of COVID-19 were recorded last March, and at the bottom right, you can see the recent statistical data on COVID-19. This pandemic has revealed key and systemic gaps and challenges in Kyrgyz public health sector. Hospital capacity was limited to deal with dramatically increased number of cases due to the weak infrastructure, insufficient management, shortage of PPE and ICU equipment, lack of drugs and medical supplies. As COVID-19 was a completely new infection, there were no evidence-based clinical guidelines and protocols for case management, especially for critical ill patients. There was a major shortage of trained medical specialists at the regional level, and physicians from the central level had to travel to the regions to provide practical assistance in the hospitals. That's why the Ministry of Health has initiated an assessment of preparedness for intensive care system, looking at needed equipment, supplies, clinical knowledge, and training. And as a result of this assessment, the MOH requested development partners for support in specific areas of need, which included procurement of ICU equipment and supplies, and enhance health worker capacity by developing an introduction of clinical guidelines and conducting in-person training and mentoring. Next slide, please. Our project, Local Health System Sustainability Project, was the first partner to provide immediate support to Kyrgyzstan, and we used the 4C approach. First, we were comprehensive. We provided a holistic approach that covered procurement of equipment and supplies, training, development of curriculums, and COP. We also were coordinated. The system in Kyrgyzstan is very complex, so all planned measures were agreed with the Ministry of Health, training institution, and development partners. So, for example, the purchase of ICU equipment and supplies was made only after extensive discussion with other donors and according to actual needs of the hospitals. We also focused on capacity building. We introduced the multidisciplinary team approach for management of COVID-19. The multidisciplinary teams included clinical professionals in specialties such as obstetrics, pediatrics, surgery, as well as human resource management experts. Almost 200 doctors and nurses of various specialties at the regional level have been trained by a national team of trainers. And the practical training were focused on skills on life-saving technologies of respiratory support, such as modes of oxygen therapy and non-invasive ventilation. And these multidisciplinary teams now are in place in all 7 regions of the country. And finally, our support has been collaborative. For example, the Medical Institute of Continuous Education provided free of charge a platform for distance learning of multidisciplinary teams. Next slide, please. LHSS was able to immediate response to the MOH needs assessment by procuring urgent needed PPE kits and high capacity oxygen concentrators. Currently, the project is purchasing basic equipment for intensive care and oxygen system support. The multidisciplinary team program created an effective system of continuous education for health workers, so we can support the granting of 28 credit hours, and the stable multidisciplinary network was established in all regions. A regional multidisciplinary council has been established just recently for regular consultation and discussion of severe cases, and WhatsApp groups were created for regular consultations and knowledge management. This approach was really and highly appreciated by the Ministry of Health because it has helped strengthen the human resources, provide better preparedness in pandemic response, and improve the quality of critical care for patients. Now, the Ministry of Health is going to extend this approach for other diseases and use it at the primary healthcare level. Next slide, please. Despite the short period of our project and given the complexity of the healthcare system during the pandemic, there are lessons learned, of course. So the early needs assessment of hospital infrastructure and practical skills of frontline doctors and nurses in using ICU equipment and their basic knowledge is essential in order to save lives in pandemic. The multidisciplinary team approach and task shifting contribute a lot to improvement of quality of critical care and could optimize the limited and unequal human resources. There are a lot of capacity and coordination framework in response to COVID exist already in Kyrgyzstan. Therefore, the clear coordination and transparent labor division with the Ministry of Health, national partners and donors are crucial in emergency response. Thank you very much for your kind attention, and I would be happy to reply to your questions later on.
Cholpon, thank you very much. That's very interesting and very nice to see that the early needs assessment was done to sort of inform the international response, and which had to be immediate when the crisis hit. So we'll come back to that some of that in the question and answer session. Our next speaker is Dr. Basheer Khassawneh, who also works for the LHSS project in Jordan, where he delivers webinars on COVID-19 case management, and he leads an ICU assessment team. His presentation today focuses on his personal experience as a specialist at the King Abdullah University Hospital in Irbid, Jordan. Dr. Basheer, over to you.
Thank you. Hello, everybody. Next slide, please. Yeah, the Jordanian response to the COVID-19 crisis started back in March when we had the first cases. During that time, we did not have many severe or critical cases of COVID-19. So the concentration of the Ministry of Health was to have a swift action against the pandemic by writing national protocols and policies on how to handle the COVID-19 epidemic, and also helped other hospitals to have their local protocols. And they started to prepare major already existing hospitals to deal with COVID-19, like 2 major hospitals in Amman and our hospital in Irbid. And these hospitals worked on educating their staff on how to triage suspected cases, where and how to admit and treat mild, moderate, and severe cases of COVID-19. And also we started to stockpile and provide PPEs and how to use them. And also we start to stockpile necessary equipment for oxygen delivery, mainly oxygen mask, ventilator, accessories, and kits, and etc. Early on, we did not have a huge capacity for testing for COVID-19, so we started to build that over the time till we reach more than 30,000 a day. Next slide. When the first real wave hit Jordan in September 2020, there was already a central committee at the national level led by the Ministry of Health that ran the show from everything from policies, procedures, distributing cases and care, and providing the necessary equipment and PPEs. And we already have the policies and procedures on COVID-19 response in place in these major hospitals that handled the first wave. And staff already acquainted and have an idea how to deal with the disease with informative webinars that were available for physicians with the help with our partners. At that time also we had adequate stockpile of PPEs. So when we had the second wave, which is the real wave in September 2020, PPEs were not a major issue. And testing also was not a major issue, especially at the local level in our hospital and other treating hospital. Also, the Ministry of Health created a central bid management office in the Ministry of Health that coordinated assigning bids among different hospitals, and especially critical care bids. So they have a real live database of how many bids and how many critical care bids assigned in each hospital, so they can move patients around and no patient will be deprived of a critical care or regular bid. And also the private sector was pitched in and was involved with their huge capacity of critical care and regular bids. And this would not have been done without the help of the WHO and the USAID funded programs. Next slide. And the case management of patients with COVID-19 at our hospital was largely based and focused on the shutdown of the hospital for the elective and outpatient procedures only for emergency cases. So we used our emergency room to triage patients and see who should not be admitted to the hospital and where to be admitted. So the emergency room was a core place for handling diagnosed and suspected cases. And also we assigned hospital wards for COVID-19 cases. We cohorted them, we prepared them to handle patients that they have a highly communicable disease, and we have patients in cohorted rooms and we have patients in private rooms. As for the critical cases, we utilized our several ICUs to handle the epidemic. For example, we started with the surgical ICU assigned, then we moved progressively as the number of cases increased. So having this infrastructure was very helpful. But the high number of patients necessitate the opening of intermediate respiratory units using regular hospital wards, and that was a major undertaken major challenge from the infrastructure point of view. I'm talking about having secure oxygen supply, secure electricity supply, have enough equipment and staff in these units. And we started to have standard treatment protocols distributing among the hospital staff and how to manage the patient. Example, how to move patients between regular beds, intermediate unit, ICU, admission and transfer criteria, how to upscale and downscale oxygen therapy from regular oxygen to non-invasive machines to ventilators and vice versa. Next slide. But that sounds like a perfect plan, but it wasn't. And there was a lot of challenges that we faced. The biggest one of them is the rapid surge in cases, rapid increase in number of admissions to the hospital, especially to the critical care area. And no matter how many ICU beds you are assigned, you still need more. That's what we learned from the COVID-19 crisis. And no matter how many ICU beds you have, still it is a rate limiting number. And that's why we have to move to intermediate care units. And as I said, opening them was a major challenge. Mainly oxygen supply, mainly having the right structure to adapt to non-invasive and high-frequency oxygen delivery devices, and the educated staff to deal with these equipments during the crisis. We have so many ventilators, non-invasive ventilators, and high-flow nasal cannulas at the beginning of the crisis, but we thought these were not. These were enough, and actually they were not. And the capacity was almost close to 100% for many days of using these equipment. So the number of these available equipments was also a rate limiting. And the variability of these equipments was also a major issue, because if you have different models, different manufacturers, this will put a strain on the staff when delivering care and using these equipments the right way. There was a high demand on oxygen supply. I'm talking about the liquid oxygen to the hospital has to be secured and delivered more often. And also the supply from the central oxygen tank to the ward, especially intermediate units, where they have these so many devices at the same time requiring high flow. These equipments, they need 40, 60 liters per minute. So that put a huge demand on the oxygen supply. This is something has to be paid attention to. And taking care of so many critical patients at the same time with so many equipments running simultaneously needs increasing number of respiratory therapists. Again, we thought we had enough of them, and actually we have to increase their numbers, and it trained other hospital staff to do their job during the crisis, and that was a major challenge to do that. Also, the number of supervising consultants, this is also was very limited. And, each one of us will be taking care of sometimes 30 patients on ventilators, non-invasive machines at the same time. There was a major challenge to deliver quality care with so many patients under your care with the same disease and high level of illness, severity of illness. Endotracheal intubation, and the time of that, it is a challenge that we faced from the very beginning of the crisis till today, that people are resistant to endotracheal intubation. I'm talking patients and their families. This is from something spread across the social media that they can be fatal or maybe fatal. Next slide. Having the numbers handy was very helpful. We have a WhatsApp group across the hospital, leading personnel that will give us daily briefings on the number of admissions, discharges, deaths, hospital occupancy rate each day, ICU occupancy rate, and also the number of equipment. I'm talking oxygen delivery equipments on daily basis. So that will give us on daily basis what capacity we have, and this helped us to move from one ICU to two ICUs assigned, opening one intermediate unit, then a second one, opening more hospital wards in advance to care for these patients on a progressive way, and also to downgrade same later in the wave. So the combination of this high occupancy rate that you see in the slide back in November, we had more than 100% occupancy rate in the ICU for days and days, combined with a high severity of illness. More than 50% of our patients required the ICU care or intermediate care unit care at one point. This led to a high number of hospital mortality of around 30% for quite a long period of time during the first wave. Next slide. Now, what could have been done differently? First is assigning a major tertiary hospital to care for COVID-19 is well and great, but this will deprive other patients with non-COVID diseases and non-communicable diseases from their proper care. So having dedicated field hospitals is important to balance between managing COVID-19 and other diseases, and Jordan built 7 hospitals for that purpose. Also, a proper training of the hospital staff in advance to take care of these patients at many levels, because some of them were not acquainted with these new oxygen delivery devices, or like non-invasive ventilators, different kind of ventilators, and how to use them, how to adjust them, how to upgrade, downgrade therapy. Having this training in advance, I think it would be very helpful to any hospital who is going to deal with COVID-19. Also having written protocols on how to do that, how to assign patients to which oxygen therapy, how to go from non-invasive to ventilator, how to go from high flow to non-invasive, how to adjust non-invasive, how to use medical treatment. I'm talking about antibiotics, antivirals, steroids, cytokine storm management, thrombosis prophylaxis, thrombosis treatment. We had written protocols for them that helped a lot, and I wish we had it earlier on. Also having adequate equipment. If you think you have adequate equipment, you think twice, because you still need more during the surge of cases. Something that should work on it on the society level too, about the balance between the prolonged use of non-invasive ventilation and the early appropriate use of invasive mechanical ventilation. The last thing is that there was a high demand for the establishing and running a national ECMO center for those young, otherwise healthy and very sick patients with severe lung disease, is something that should be thought about in each country. And I think this is my last slide. And thank you very much for your listening.
Thank you, Dr. Basheer. Fascinating, and very interesting to hear that. I mean, the big surge came late, or later than many other countries in Jordan, but even then, you still had these huge difficulties to overcome. And we'll come back to some of the points you raised, I'm sure, in the question and answer session. So I'd now like to introduce Dr. Michael Lipnick. He's an anesthesiologist and intensivist at the Zuckerberg San Francisco General Hospital and co-director of the University of California San Francisco Center for Health Equity in Surgery and Anesthesia. He's a director in the Hill Global Health Fellowship and a director of the UCSF Institute of Global Health Sciences faculty program. Michael, we are delighted to have you with us, and over to you.
Thank you very much. Delighted to be joining the panel today. What I'm going to be sharing in the next few slides is a bit more of a macro perspective, but you'll hear many of the same themes that have been highlighted by the co-panelists already today. Next slide, please. Now, before we get into the challenges of 2020 and COVID pandemic that continues, I wanted to take a minute to highlight some of the barriers to providing ICU level care and resource variable settings around the world that existed before COVID. Workforce shortages have been something that has been a significant challenge for many years, not just the number of workers, both physicians, non-physicians, respiratory therapists, but also the training available, both the training at the time of foundational training and also opportunities for ongoing continuing medical education, CME or CPD. Fundamental infrastructure challenges have always existed and have been highlighted by the current pandemic. These include oxygen, access to oxygen, adequate amounts of oxygen, also essential medications, fluids, antibiotics, analgesics, things that in some settings are taken for granted, but are not often the case. And then also other additional fundamentals like PPE. Lastly, barriers to providing high quality critical care that existed prior to the pandemic included standardization of implementation of existing protocols that we know are data driven. And one example specifically would be protocolized therapy for patients who require mechanical ventilation. Next slide. Now, 2020 began with, and even 2019 began with limited access to information. Everybody watching, trying to see where this would go, but the year ended very differently with the deluge of information that rapidly accelerated. Over the course of the year, some of the things that I'm highlighting here on this slide, access to diagnostics, PPE, mechanical ventilation became a defining feature of the, or a defining theme, even though as highlighted, the number of patients who require mechanical ventilation is relatively few compared to those that require other forms of oxygen delivery. Workforce shortages, access to oxygen, and as mentioned, the shift from limited access to information to huge amounts of information became something that also defined much of 2020. By the end of 2020, the trajectory was set to produce nearly 200,000 publications, both print and preprint, which is highlighted in this graphic on the right. Next slide, please. Now, these are just some of the topics that have received a lot of attention, both social media, numerous publications, and rumors, data, changes in guidelines. What you're looking at is these are panels that we've created on a dashboard. We created this to try and understand where there is consensus in therapy, where there is lack of consensus, and how things are changing, how to disseminate what is a large amount of rapidly changing information in clearer ways. So suffice it to say that in some cases, the consensus has moved towards, has increased over the year, but there are many therapies that where there is still a lack of consensus, evolving data, really recommendations that are heavily qualified and conditional, as you see for convalescent plasma as one example. Next slide. Now, there have been a handful of other topics that have received a lot of attention over the course of the year. The concept of the happy hypoxemic, silent hypoxia, people who don't appear to be very unwell but have very low oxygen saturations. This is something new to COVID-19, which it is not, although certainly is something that we are seeing. There were rumors that COVID-19 was similar to high altitude disease and should be managed similarly. This is something that is not true. But some of the ongoing discussions where we don't have a lot of data to guide include how best to manage patients with respiratory failure. Earlier in the pandemic, again, a lot of data and social media buzz about avoiding intubation at all costs. That was a change from early in the pandemic when it was intubate everybody as soon as possible because they deteriorate rapidly. Neither of these has really been borne out by the evidence, and we're kind of coming back to data-driven protocols that pre-existed COVID for the majority of management of respiratory failure in these patients. Next slide. Now, mortality rates has been a big discussion. As Bob had highlighted earlier on, early reports of mortality rates were extremely high and concerning, ranging from 50 to even 90% for patients that required ICU and mechanical ventilation. And the big question was, is this inherent to the virulence of COVID-19, or is this more a reflection of how healthcare systems are managing these patients? Next slide. Now, what we have learned and data even from early in the pandemic was supporting this finding was that these high mortality rates were found primarily in centers that were overwhelmed, in centers that had high surge and shortages in some of these key infrastructure that we have spoken about: workforce, oxygen, PPE, et cetera, access to diagnostics and therapeutics. For centers, even from the beginning of the pandemic, predating widespread implementation of therapies like steroids, the mortality rates that were reported from centers that were not overwhelmed were comparable to the rates that we were seeing for mortality from other patients admitted to the ICU with respiratory failure, more around the 30% range. New slide. Thank you. Now, in terms of lessons learned from COVID-19, the co-panelists here have highlighted many of them which have universal applicability. There are a few that I wanted to add onto that. One is that really any facility anywhere can be overwhelmed by surge, regardless of how well equipped the facility is prior. There are no facilities that are set up specifically to handle this huge influx of patients over a short period of time. Another lesson learned is that equipment and supplies are certainly necessary, but really only a piece of the puzzle. Training, workforce expansion, and then also some of these other things that I've highlighted below are key pieces of the puzzle. One is too much information can be a challenge. Social media and popular press, even the literature can be overwhelmed with information, making it difficult not only for healthcare providers, but also patients to understand and figure out what the best course of action for treatment may be. Regional load balancing systems is worth mentioning. In many settings, certain facilities were overwhelmed, certain cities or even parts of cities were overwhelmed, whereas other parts within the region were not. Yet systems to help redistribute, whether it's ventilators or workforce or other equipment, were lacking. And although these systems are being expanded, there's still work to be done there. Another kind of theme that emerged was the number of groups building ventilators and other new respiratory care equipment without adequate testing. This, of course, well-intentioned out of necessity, but does require some caution, and certainly a bit more than was exercised by many of the groups attempting this. And lastly, many lives with COVID-19 can be saved with low-tech interventions, namely access to oxygen, which again predated the pandemic. Final slide, please. So to wrap up, in terms of moving forward, the implications for the future for respiratory failure management, there are going to be a lot of data coming out and time to go through the data and better understand how practices that predated may or may not be how we manage patients with respiratory failure for COVID-19 and other causes moving forward. The amount of data is going to be unprecedented for studying that disease process. Work to be done in identifying optimal staffing and facility models for dealing with surge that may have implications for how we deal during non-surge times. And then finally, oxygen infrastructure and workforce, key bottlenecks in the provision of critical care in many settings globally. Investment there is sound. It was prior to COVID and will remain so. And I think the pandemic has highlighted these areas and likely to have significant positive impact moving forward. Next slide. I appreciate your time today, and this is the link where you can find some of the guidelines that I had highlighted earlier. Thank you very much.
Michael, thank you very much indeed. That was, again, fascinating. Very interesting to see you putting out some sort of simple truths that we can all learn going into the future. So thanks very much. We'd like now to move to a question and answer portion of the webinar. I'd like to encourage all those listening to submit questions into the chat box. We have quite a few coming in already. And I'm going to put those to the different panelists, but keep them coming in. So I'd like to pass on some of the questions now. First one to Cholpon about in Central Asia and Kyrgyz Republic. There's a question, could you say a little bit more about the size of the support that you were involved in? I mean, how many hospitals across the country were you able to support? Cholpon, over to you.
I would like to say that within the short period of the project implementation, we have already equipped 4 big hospitals who are serving the majority part of patients with COVID. It's 2 tertiary level hospitals. One is infection disease hospital, which covers all patients from all over the country, and the national hospital. And mostly we are supporting the intensive care units and departments. And also, as the outbreak was started in the south of the country, we also focused our support in equipping of the southern regional hospitals, which serving the patients with COVID and complications. So our support was not only limited by providing of equipment, as I said, by oxygen concentrators, but also we have already procured some equipment which would be needed for oxygen system, like laryngoscopies, oxygen concentrators, mobile X-ray that are really needed for this intensive care unit and very costly, and the hospitals and the MOH could not afford in procuring it. And according to our approach, along with procuring of equipment, we are supporting the medical staff in training. So the suppliers are always providing in-person training how to use the procured equipment, and from the technical part and also from the clinical part. So we do have the team of national experts who are supported the practical doctors and nurses in the clinical part of using this oxygen and ICU equipment.
Cholpon, thanks very much. I'll move on if that's okay. We've got a few questions coming in, but that's excellent. Thank you. One for Dr. Basheer around protocols. So you mentioned WHO in your presentation, but what other references and sources of information did you use, or were you able to use, that were useful in writing your treatment and care protocols?
Well, the writing in protocols and dealing with them was very dynamic throughout the pandemic. As you know, things were changing continuously, and data was coming almost on a daily basis. But basically, the Ministry of Health had a treatment protocol. There was a central protocol that they asked everybody to, or oblige everybody to adopt. And it's based basically on the WHO mainly, but we modified that from the CDC. We use some stuff from the Society of Critical Care Medicine. Also, up to date, they had updated information on how to manage COVID-19 patients. And we utilized some of the European experience. It was presented in the ERS meeting back in September, and also through the, I think, the ACCP meeting, American College of Chest Physicians. So it was a combination of all of that. You know, there was nothing specific, but mainly it was WHO because it was more applicable to Jordan.
Thanks, Dr. Basheer. That's very helpful. I'm going to ask Michael, over to you. There's a question around long COVID. Wondered if you could say a little bit about that, about how do you manage long COVID when people, as they after their intensive care period, and is there anything you can say about how care can help reduce? What is there evidence about how long COVID could be reduced in such cases?
Thanks for the question, Bob. To be honest, most of my care with patients has been in the intensive care unit. And so other members of our team have more experience with long COVID and taking care of patients. It's an active area that I think we're just sort of beginning to scratch the surface of and understand what is happening after patients are discharged. Not to sound like a broken record, but follow-up and long-term sequelae of many critical illnesses is something that has received relatively little attention historically, including those with respiratory failure. So I think it's an important area that we are trying to learn more about. But at this time, I'm not able to provide any more specifics about that management.
Michael, thanks. Yes, well, Cholpon and Dr. Basheer, when we come back to you, maybe you might want to dwell on that as well. So Cholpon, can I come back to you? There's a question about the role of primary care, because a lot of the talk today obviously is around critical care and hospitals. But what's the link, any important links and messages for the primary care level around this critical care issue in COVID? Cholpon.
Yes, I would say that the primary healthcare level is the most important, and the first who is taking the whole, how to say, response to this pandemic. And unfortunately, the primary healthcare level system is not well organized in our country. Is being reforming within the current ongoing healthcare sector. However, within our project, we supported the Ministry of Health in development of clinical guidelines and protocols based on WHO recommendation, and based on that, the training curriculum was developed and immediately introduced using the distance learning platform for a majority of the primary healthcare workers, because it was lockdown regime, and it was quarantine. Nobody was allowed to travel to the regions. That's why the only way was to use the appropriate distance and virtual platform for the introduction of clinical guidelines and protocols and standards. And believe me, it was very difficult to organize the practical doctors and nurses for this distance learning because of lack of IT knowledge and computer skills. But nevertheless, we were so amazed that almost 400 primary healthcare providers were joined these distance courses, which were almost 2 months under support of our country. And now our project is going to support the improving their IPC and waste management system in our pilot primary healthcare facilities, because this system is still weak. And in response to the second wave of the COVID, now we are going to build capacity of the primary healthcare workers in response to COVID, with the enhancing their skills and knowledges, how to better make safety procedures, how to be safe, how to create the safety environment for patients and for themselves. But it's a very good question, because primary healthcare level is always outside of the system, and the major focus is going to the hospital level. But this is needs to be changed and shift more focus to them. Thank you.
Chopin, thanks. Dr. Basheer, I'll come back to you for the next question, but also please comment on any other questions that have been raised before, if you wish.
Yeah.
So we have a question. Yeah. Maybe I'll just give you an additional question, and then you can see how you want to respond. We have a question around. There's been a lot of presentations were on the inputs, personnel, equipment, supplies, and maybe you could say a little bit more about the processes of care, how that was changed, and what was learned around the actual care process for COVID-19 patients. But please respond to other questions as well. Dr. Basheer, over to you.
Regarding the long COVID syndrome, or in a country like Jordan, patients when they're discharged from the hospital, the only place that they had to go home is to go home. We don't have nursing places. We don't have a hospital care facilities. So patients will stay in the hospital until they are stable to go home on a reasonable amount of oxygen that can be supplied at home. So there was a huge demand in Jordan for oxygen concentrators, especially for the 10-liter ones. So there was a big market for that. So patients will be discharged home on oxygen concentrators. And during the limited time of follow-up that I've seen, the ones who survived and came to the clinic, it seems to be the post-acute COVID, it seems to be variable. Some of them will recover quickly, and some of them will be left with looks like a chronic lung disease. And time will tell if this will be a long-lasting process or not. And some of the patients, we kept them on, a regimen of steroids, oral steroids. This is about the post-COVID. So it is mainly tapering oxygen, using oxygen concentrators, and some of them, they needed steroids. Another thing that we noticed, some of them came back with pulmonary embolism and DVT. So maybe some of these patients, especially the limited mobility ones, they may need some sort of DVT prophylaxis. And I know there's some protocols for that. as for the change in the management, what we've noticed that is that the non-breather oxygen delivery device is very effective. And I'm glad that we stockpiled thousands of them before we had the first wave. Non-breathers are very, very helpful in providing adequate oxygen, and they are really liked by the patients. We found them to be more effective than the high-flow nasal cannulas. High-flow nasal cannulas were the least effective ones for some reason, in my experience. What we learned also that, patients and their family insisted on using non-invasive ventilation for a long time. And I don't think that was very useful. I don't think using them for more than 2-3 days at most is helpful. It can be also dangerous, and I wish there was a way to convince them. These patients were awake and they're making their own decisions. It was very hard to, put them in the ICU, intubate them while they're refusing to do that. So, prolonged non-invasive ventilation was, the outcome was poor. Also, what we noticed that other people notice is that no matter what you give for DVT or pulmonary embolism prophylaxis, the patients do develop sudden oxygen desaturation, sudden cardiopulmonary events. And I believe these were pulmonary embolisms because there was no X-ray changes, etc. Suddenly the patient will collapse. So I think there is a high rate of venous thromboembolic events in these patients. This something has to be keep an eye on. These are some of the stuff that I noticed that strike me now.
Dr. Basheer, thank you very much indeed. Michael, back to you, if I may. Please respond to any other points that come up as well. But there are several questions around health worker burnout, and obviously we've been seeing that in the news as well. Are you seeing that as another factor in affecting the care of patients? And is it an issue that's requiring of more attention? Michael, over to you.
Thanks, Bob. It's a very good question, and it is definitely something that we are seeing. I think many settings are seeing this. Healthcare workers are, in many settings, stressed not just by the hours, the volume, but also the severity of the illness, the mortality. All of that is also compounded by the fact that this is happening during a time of social isolation for communities, including healthcare workers and their families, and also for healthcare providers. I think an additional source of stress and anxiety from this pandemic is the inability to interact with patients and especially their families in a way that we are used to, in a way that is important and central for not just routine daily care and patients who are going to survive, but especially in patients which are approaching the end of their life, which is unfortunately many of the patients with COVID. The inability to interact with families or facilitate families being with their loved ones has been an additional source of stress and anxiety. So for many levels, that has become an important, it has always been, but has become more prominent as an important topic. And as the pandemic continues, with in some countries, variable and uncertain timelines really lie ahead. Strategies to mitigate some of this is going to be a very important part of the ongoing response.
Michael, thank you very much indeed. Chopon, Dr. Basheer. Dr. Basheer, yeah.
I see several questions on the chat. Should I comment on them or?
Well, we're trying to go through them systematically. If there's one that you particularly would like to respond to, please go ahead.
I have a question about the hospital shutdown. The Minister of Health learned early on that they wanted these patients to be taken care of in well-equipped hospitals. So they chose 3 well-equipped hospitals from staff, equipment, infrastructure. And these, the 2 hospitals, Amman, were completely shut down. Queen Alia Hospital, Prince Hamza Hospital, and were converted into COVID-19 hospitals. Everything in the facility was converted into the care of COVID-19. Our hospital was shut down for the elective and outpatient services, and we continue to run emergency services, let's say cardiac cath, emergency surgeries. Some of the cancer patients continue to get their care, but on limited basis. That's what's meant by hospital shutdown. As for the private sector in Jordan is a capable sector. They have very well equipped hospitals from staff, infrastructure, equipment, etc. And Jordan is a third world country, but it has a lot of capable and well-to-do people, and they chose to go to the private hospital to be treated. So they took care of a good number of patients, and the Ministry of Health at one point had an agreement with them to also take care of some of the people, general public, to be taken care of in certain private hospitals. So they played a role. Their ICUs, their wards, at one point were taking care of both private patients and Ministry of Health patients. These are my two comments. Sorry for the interruption.
No, Dr. Basheer, that's excellent. There's one other question that was for you about how to adjust the demand for health workers and how you manage that in your.
That was one of the major challenges, and I mentioned one of them, which is the respiratory therapists. So we trained anesthesia technicians during the crisis to take care of these patients, but that was not easy. Not easy, not ideal. Second, we mobilized the nursing staff from other wards because the hospital was shut down, and also they had ongoing training, and they participated in the care of patients. So we mobilized the staff, nursing staff from the whole hospital to take care of COVID-19. Initially we used the medical residents. We had good number of them to take care of COVID-19, but at one point we had to mobilize residents from other specialties. We used neurology, dermatology, psychiatry because they do medicine training. But eventually we use, second, third year residents from other specialties to take care of COVID-19. So also for the patients who did not need lots of care, on face mask, oxygen, have some comorbidities, our other medical colleagues, even gastroenterologists, nephrologists, pitched in and took care of these patients. So, we mobilized quite a big number of the hospital staff because of the shutdown to help with the care, because staff burned down was a major issue, and also hundreds of them were infected with COVID-19, and they have to take at least 10 days sick leave. So that also increased the the demand for using other hospital staff. But we did not need anybody from outside the hospital. We were contained in our care of these patients.
Dr. Basheer, thank you. Cholpon, can I ask you about financing all these changes in the Kyrgyz Republic? How did the country mobilize funds to be able to make all these changes that you talked about?
First of all, the country has already established their special fund, the government fund, epidemiological fund, which is being used for critical measures, for example, for organizing some trainings, for procurement of basic and essential equipment. So this is the government contribution in response to COVID. But unfortunately, our countries fully depend on the donors' investment and development partners' contributions. But at least within our project, we are trying to build the sustainable system of the multidisciplinary teams at each region that could, having this increased knowledge and skills in managing of COVID, and they can use their knowledge and skills in order to train the other staff within the regions to change their knowledges and skills and at least to create some, networking of specialists who can support during emergency situation. And as I said before, the Kyrgyz State Medical Institute of Continuous Education is going to integrate the multidisciplinary team program to the continuous medical education with giving their curricula, with granting of the credit hours, and etc. So we are somehow trying to make our measures more sustainable.
Cholpon, thank you very much. So into the last couple of minutes now, so I'll go across the panelists and ask for any final comments. Michael, I'll start with you, if I may. There's also a very specific question for you about what are your thoughts about proning patients to delay intubation? So maybe you might want to tackle that one, but then please do any final comments or thoughts from the other questions. Michael, over to you.
Thank you. It's a good question. And the data are evolving on how best to utilize proning. The most guidelines, and certainly our practice in the facilities where I work, has been to not use proning as a way to delay intubation. If patients meet criteria for intubation, then we are not delaying intubation. But we are using proning to help improve oxygen delivery and improve the ability to maintain a higher saturation in patients who are requiring oxygen therapy but not meeting the criteria for intubation. We don't have enough data to tell us, is that in essence delaying or keeping some patients from requiring intubation? I think that is the hope, but we don't know that yet, and we're not using it for patients as a salvage if patients meet criteria for intubation. I hope that answers your question. And just skimming through the other comments in terms of final thoughts, the resources that I had shared, please feel free to be in touch with us. If you have questions, please share them. Please let us know ways that we can make them more useful. We are trying to work with WHO through USAID with their support and other partners to try to not reinvent the wheel. There's a lot of information and resources out there. So in many cases, what you see on these sites does represent a collaborative effort with those institutions to try and harmonize rather than create parallel tools and systems. Any feedback is very welcome, and thank you again for the opportunity to join today.
Michael, thank you. Thank you. Dr. Basheer, any final thoughts? Dr. Basheer, you're silent at the moment.
You. No matter what you think you're prepared for dealing with the surge of cases, you'll be overwhelmed very quickly. So I advise that anybody is going into this to be very well prepared, especially for the PPEs, the oxygen delivery device. And as Michael mentioned, oxygen delivery, simple oxygen delivery device, from just having the oxygen ready to have the simple oxygen masks. And you also, staff who are caring for these patients also should be mentally and psychologically prepared that there is a increased morbidity and mortality with this disease. And sometimes, since we don't have any specific treatment for it, there is a high mortality, and you have to accept that. Third is I would work on training more staff than I would initially think I need, and I have the material ready for them to be trained on. I'm talking about physician, respiratory therapist, and nurses. These are probably the three essential parts of that. I think these are my last thoughts on the. And thank you for allowing me to talk and listen to our experience.
Dr. Basheer, thank you. So Cholpon, final word on any final thoughts.
Thank you very much. It's really so exciting to participate in this such a big event, and I really want to say that the most important from our side is to be more responsive to the needs of the country, to the Minister of Health, to the hospitals managers, because I think that the beauty of our project was that we were always flexible, we were responsive, we were trying to meet in person with the hospital managers, with the senior management and the Minister of Health, and to hear the voices, to really understand how in difficult situation they are now being, and really to immediate response to their needs, and even to provide some moral support. I think would be very helpful, that they could see us as a part of this big team in response to COVID. I think it's really important to listen to our partners and to support them. Thank you.
Chopin, thank you very much. So thank you very much to our three panelists. It's been an excellent discussion. Thank you. Thank you very much to those who listened and sent in questions. The session has been recorded and will be sent round to all those who registered, so you have another chance to share with others. Thank you very much to everybody, and I look forward to this learning continuing. As we know, quality improvement is fed by learning, and we need to do more of this. So thanks for the panelists for that, and thanks for everybody else for contributing. Okay, cheerio.